Welcome to Pathology Pebbles. The topic is G6-PD, glucose 6-phosphate dehydrogenase deficiency. Starting with anemia. Anemia is functionally defined as an insufficient RBC mass to adequately deliver oxygen to peripheral tissues. To establish presence of anemia, we can perform on whole blood either hemoglobin concentration, hematocrit, or a RBC, red blood cell. Anemia can be divided into the microcytic, normocytic, or a macrocytic. Another classification is etiological classification of anemia either due to the impaired red cell production or due to the increased red cell destruction. Due to the impaired red cell production is mainly due to the vitamin deficiency or iron or a vitamin C deficiency. Due to the increased red cell destruction, again divided into the intracorpuscular defect and extracorpuscular defect. Intracorpuscular defect again divided into the hereditary and acquired. Hereditary enzyme deficiencies is G6PD deficiency, while acquired enzyme deficiency is PNH and secondary to liver disease. Another is membrane defect like hereditary spherocytosis and hemoglobinopathies, while extracorpuscular defect include immune hemolytic anemia and fragmentation syndrome. Inheritance of G6PD deficiencies, it is X-linked recessive disorders. Another X-linked disorders are hemophilia A and B, color blindness, Becker muscular dystrophy, Duncan muscular dystrophy, Fragile X syndrome, and Leach-Nyhan syndrome. It is more common in males as compared to female. Prevalence and geographical distribution. Among Indian males, prevalence of G6PD deficiency is 2.6 to 3%. Starting with WHO classification of G6PD variants, it is divided into the class 1 to class 5 according to the activity of G6PD enzyme. In class 1 and class 2, activity is less than 10% of normal, while in class 3 it is 10 to 60% of normal. In class 4, it is 60 to 100% in normal. In class 5. Starting with glycolysis, due to the lack of mitochondria, RBC relies on anaerobic glycolysis for metabolic requirements. Main pathway is glycolytic pathway, which takes up 90% of glucose, while HMP shunt pathway takes up 5 to 10% of glucose. It is protective pathway which inactivate intracellular oxidants like superoxide O2, H2O2 with glutathione. Another endogenous and exogenous antioxidants are superoxide, glutathione, ceruloplasmin, transferrin. Exogenous are vitamin A, E, and ascorbic acid, which is vitamin C. Moving on to the pathophysiology of G6PD enzyme. So, glucose is converted into the glucose 6-phosphate, and glucose 6-phosphate is converted into the 6-phosphogluconate in presence of glucose 6-phosphate dehydrogenase enzyme. And this G6PD enzyme convert NADP into the NADPH, which reduce glutathione with help of glutathione reductase and convert H2O2 into the H2O. Now in G6PD, if there is an oxidant stress, lysis of old RBC in circulation, which are more deficiency and enzyme, so there will be hemoglobinemia and hemoglobinuria. And this hemoglobin is absorbed by the renal tubular cell. Hemoglobin hemosiderin accumulates into the tubular cells, and there will be hemosidenuria. There will be extravascular hemolysis. Whenever there is oxidant stress, red cell deficiency in G6PD, there is a depletion of NADPH and GSH and GSS, which is glutathione. So oxidant stress is not hydrolyzed due to the lack of glutathione. Oxidation of self-hemoglobin containing protein and denatured globin is formed. And this self-hemoglobin attached to the RBC membrane forming Henne's body, and removal of hands body in spleen which create the bite in a red blood cell, so it is a bite cell, and there will be extravascular hemolysis. So hemoglobin finding will be abrupt fall in hemoglobin, which is 6 to 10%, and there will be reticulocytosis. Another peripheral smear finding is moderate anisopoikilocytosis, polychromatophilia, bite cell, blister cells, and Hans body. Polychromatophilia can be appreciated on a peripheral smear. So in peripheral smear, there will be various colors of RBC is seen. It is known as a polychromatophilia. Another is bite cells. As a spleen removes Hans body along with a part of RBC, a bite is created into the red blood cell. Another cell is blister cell. RBC contain coagulum of HB that has separated from the cell membrane, leaving an unstained non-HB containing cell. There will be reticulocytosis. Reticulocytes and Hans body will be seen in a supravital stain like methyl violet, crystal violet. So it is a Hans body. Denatured globin forms self hemoglobin which attach to the red cell membrane stained with a methyl violet. And this image is showing moderate anisopoikilocytosis. So there is a various shape and size of RBC, like the P is showing elliptocytes. So there is damaged red blood cell in G6-PD deficient patient. In malaria, G6-PD deficiency is protective as a host RBC kill the parasite inside the red blood cell. Another human genetic resistant to malaria, sickle cell and hereditary elliptocytosis and Duffy antigen. These all are human genetic resistant to malaria and it gives protection. Moving on to the clinical features, the patient of G6-PD deficiency can be presented as either with acute hemolytic anemia, favism, neonatal hyperbilirubinemia, congenital non-spherocytic hemolytic anemia, or maybe asymptomatic. In acute hemolytic anemia, due to the exposure to the drug, infection, or a diabetic ketoacidosis, there will be severe hemolysis of all RBCs. So the patient present with pallor, jaundice, dark urine, abdominal back pain. But this episode is self-limited because of old RBCs are replaced by the young RBCs and patient can be function normally. Another one is favism. It is named due to the mainly this episode developed after the consumption of the fava beans. Susceptible variants are G6PD Mediterranean, Asian G6PD, and the clinical features are headache, nausea, back pain, chills. Another is neonatal hyperbilirubinemia. It main causes impaired liver clearance of bilirubin. Susceptible variants are G6PD Mediterranean, Southeast Asia, China, and G6PD Canton. Another is congenital non-spherocytic hemolytic anemia. There is chronic lifelong hemolysis in absence of infection or drug because it is classified in a class 1 G6PD deficient patient. Diagnosis is mainly done by screening tests like methemoglobin reduction test, ascorbate cyanide test, fluorescent spot test, cytochemical test, and dye decolorization test. Methemoglobin reduction test is mainly based on a principle of ability of red cell to reduce methemoglobin in a normal hemoglobin. Methemoglobin is a Fe plus 3 ferric, which cannot deliver oxygen efficiently, so it should be reduced in a Fe plus 2 ferrous state to deliver oxygen efficiently. So in a G6PD test, we measure the ability of red blood cell to reduction of methemoglobin in normal hemoglobin. By this, we can assess if there is a presence of G6PD deficiency or not. Another test are ascorbate cyanide test, fluorescence spot test, and cytochemical test. Confirmative tests are quantitative G6PD assay. Normal G6PD enzyme value is 6 to 10 units. So there is the quantitative assessment of G6PD enzyme. Other serological tests are serum LDH, which is increased, cum test will be negative, liver enzyme will be normal, while serum heptoglobin will be decreased because it is decreased in intravascular hemolysis. Main management would be avoid drugs. Drugs like anti-malaria drugs like primaquine, chloroquine, and another sulfaquine and few antibiotics should be avoided. Maintain adequate hydration, adequate urine output during the hemoglobinuria. This is the difference between the intravascular and extravascular hemolysis. Main difference would be in intravascular hemolysis, there will be hemolysis inside the vessels. So there will be hemoglobinuria, hemoglobinemia, and there will be decreased serum heptoglobin because free red blood cell will be bind to the heptoglobin. It is mainly seen in G6PD deficiency and paroxysmal nocturnal hemoglobinuria. And there will be reticulocytosis increased in indirect bilirubin that will be also seen in extravascular hemolysis. In extravascular hemolysis, there will be normal or decreased serum heptoglobin and normal plasma free hemoglobin. And there will be no hemosidenuria or hemoglobinuria. It will be seen in thalassemia, sickle cell anemia, hereditary spherocytosis. All this will have extravascular hemolysis. In G6PD deficiency, there will be both intravascular as well as extravascular hemolysis will be seen. While in paroxysmal nocturnal hemoglobinuria, there will be intravascular hemolysis. Thanks for watching.